who passed the exam in November. So we're trying to incorporate sort of the new things that have occurred due to the lockdown and a lack of patient actual presence in the exam. Okay, it still is going to be an intermediate station, 15 minutes each. It might be a case of you having two examiners asking you questions, or it could be a case of you have one examiner pretending to be a patient. You will have 5 minutes to take a history, 5 minutes examination, and key 5 minutes discussion. Likewise, the upper limb and lower limb, you will again have free 5 minute sessions. It might be they show you pictures and try and go through a discussion with you about the pictures and simply just describe what you see. Okay? Examiner's manual. So we've all seen this screen and seen this sheet before. It is very straightforward. We do this day in, day out, but it's kind of like doing a driving test. So remember to check your mirrors and check your tires. The whole works as if you're doing your driving test again. Likewise, when you do a clinical examination, but again, you're not a medical student, you're not a registrar, you're trying to become a consultant. So you're trying to present the fact that you know your stuff and that you are comfortable doing this. So it's really important, I would suggest, that before the exam, you spend plenty of time practicing with other colleagues doing the exams to get an idea and a feel of how to do this. So with the intermediates, you're going to have a history. Examiner either acting as a patient, as we said before, with both candidates and examiner performing the act. So the exam will be, I'm a 65-year-old lady, I've got whatever rheumatoid arthritis, and they'll go through that with you. It could be an examiner also telling you what do you want to know from a history, much like you would have maybe in an upper limb pathology viva. More difficult as the questions can be more about how do you justify those history questions. Why are you asking about a family of neurofibromatosis, for example, or a person with, I don't know, rheumatoid again? Make sure every question is justifiable because they will grill you on it and you don't want to waste time, okay? The key thing about the history is they want you to demonstrate professionalism, a quality of history obtained, and it's organized. It's not all over the place. It's relevant to what you need to know. An ability to communicate with the patient, in this case, the examiner. So they could also throw in a consent style procedure where they ask you to, how would you go through consenting this patient for an operation after you decided what your treatment options are? They also want you to think about the social implications of the condition. How does it affect their day-to-day life? So do ask them what occupation they do, what hobbies they do, particularly in upper limb. If they're right hand dominant and they've got problems with the right hand, they want something being done about it. It's also key to know about comorbidities because, again, you're a surgeon. You want to know, I can do this operation, but is there anything that this patient has that will stop me doing the operation? Also have the ability to summarize the important history points. This is where it's key. So a very nice question that you could do in the past was say, the patient, can I just summarize to you key issues that you've told me? This time round, you'll have to summarize to the examiner. So it's good to practice with your friends and colleagues beforehand so you get used to that concept. Again, simple things, as I said, it's like a driving test. Introduce yourself. Think about the presenting condition. Think of any red flags, very key in spinal problems. Treatment so far is also important. And patient expectations, again, social implications and things like that. It is really important you ask these questions. And past medical history, any previous surgery, relevant issues. And drug history is key. Anticoagulants, they love them because they want to know, do I need to stop this patient being on a rivaroxaban or a pixaban? How long do they have to be off it? And diabetes, do they need to be first on the list, last on the list? Again, as I mentioned before, hand dominance, particularly with upper limb cases, occupation, and they do want you to ask about smoking. As I said in this, always think about summarizing to the patient or the examiner if you can. And think about differential diagnosis because they might actually have a few streams to ask about that. And without the patient there, they do actually get a chance to question you about your differential diagnosis more than in the past. Now, the examination bit is difficult. It's with no patient, it could just be a clinical photograph. And you'll have a lot of that in the short cases. And it's very much a simple case of say what you see and try and be exact about it. Again, you can't do a field, no patient, not usually critical in the case, they will try and do. they will ask you about move, and they might ask you to demonstrate how you'll ask a patient to move their arms if you're doing a shoulder exam, for example. Now, they will definitely ask questions about special tests. So think of the principles, the steps, and significance, and what a false positive and a false negative might be. I used this book by Nick Harris and Faisal Ali, and I suspect if I'm an examiner, that's the book I would have on my in my lap, on my wherever I am in my hotel room before the night before, trying to remember how to do a simple special test like a ACL anterior draw or Lachman's test. And if you can get not quite word perfect, but near enough what's said there, I think the examiners will be happy. Okay, now the discussion. It is basically a 5 minutes fiver. A long 10 minutes passed with many positive findings, so you need to get those all in. If you can write on a piece of paper to help you remember key features. Think of a list of investigations with expected positive findings. And you need to demonstrate ability of higher order thinking to score more points. Now, it is really, really important that you get to the discussion. You don't get a score. If you don't get a score for the discussion, you're not going to pass the station. And it tends to be you'll get the same score for your history and examination as you do for your discussion. So the discussion is key. So try and move swiftly, but efficiently, obviously, through the history and examination. They will draw you back if you're not getting there, but try and get to the discussion. The examiner is going to want to help you get to the discussion. And actually, in this instance, it's a little bit more straightforward. You can sometimes, I've heard of the nightmare stories where you have a patient who won't stop talking. And before you know it, you've had 10 minutes on history and all they've done is told you about their train set. So that's one skill you don't have to worry about, trying to move a patient on politely and not too surreptitiously. But you need to get to the discussion, okay? Short cases, as we said before, it's most likely going to be clinical photograph only. Again, describe what you see. Give a differential diagnosis, starting with the most relevant. We don't want weird and wonderful. If you start with weird and wonderful, they'll focus on the weird and wonderful, and you'll have to start, and you might end up digging yourself a hole. They will also, again, ask about special tests to help confirm the diagnosis, and also how they might guide your management for the diagnosis. Do ask for investigations. There might not be any x-rays, but if they are, brilliant. But if not, say what you might expect on the findings. And again, think broad management lines, so non-operative, operative. And again, also, it's key as well to say you would ask what the patient wants. That's a very important question because patient expectation is key in this as well. There's a very simple thing they used to do as well in the clinical, the short cases. They would ask you, what do you think? What question would you like to ask the patient? So have a think about that as well. That's the end of my discussion, my presentation. So I wish you all the best. It's strange times, but plenty of practice will help you get through it. And I'll leave you back to Firas.
Thank you very much, David. It's really nothing much I could add to that. It's perfect within the time limit. Covers everything, and I hope you guys have made notes and taken everything. I think David here speaks with a lot of experience with exams. So I think everything he said is extremely valuable here.